Hello everyone, now let us discuss about 2023 ICD-10 coding guidelines for Chapter 18, which covers symptoms, signs and abnormal clinical and laboratory findings not elsewhere classified. Now, under that session, we will be discussing when to use the symptom codes, guidelines regarding the use of symptom code with a definitive diagnosis code, combination code that includes symptoms, repeated false, guidelines regarding the Coma scale documentation, guidelines regarding the search due to non-infectious process, when to code death NOS, and finally coming to guidelines regarding the NIH-SS stroke scale. Now let us discuss regarding the first guideline, use of symptom codes. Codes that describe the symptoms and signs are acceptable for reporting purpose when a related definitive diagnosis has not been established. Whenever there is no definitive diagnosis regarding the clinical problem, then you can use symptoms and signs as codes. Let us see an example. Patient presents with atypical chest pain and lethargy. He is referred to cardiologist for further workup. Here definitive diagnosis has not been confirmed and the physician has suggested for cardiac workup. So here appropriate codes are symptom codes. The first one is atypical chest pain, which is given by R07.89, and lethargy, which is given by R53.83 other fatigue. Since in this case there is no definitive diagnosis, no definitive confirmed diagnosis, here you can quote symptoms. Now coming to next guideline, use of a symptom code with a definitive diagnosis code. Codes for signs and symptoms may be reported in addition to a related definitive diagnosis. When the sign or symptom is not routinely associated with diagnosis, such as the various signs and symptoms associated with complex syndromes. There are two scenarios here. Whenever the symptom is unrelated to a definitive diagnosis, then also along with definitive diagnosis, you can code the symptom. And second case, whenever symptom, it belongs to definitive diagnosis only, but it is not common, not routinely associated with the diagnosis. In that case also, you can code that symptom. And the definitive diagnosis code should be sequenced before the symptom code. Second case is signs or symptoms that are associated routinely with the disease process should not be assigned. For example, in our current example, patient presents with left knee pain due to osteoarthritis of left knee. Here, knee pain is an associated symptom with osteoarthritis. So, since it is associated and it is inherent, here you need to code only osteoarthritis. Coding of knee pain is not necessary. But additionally, patient also complains abdominal pain. Patient presents with left knee pain due to osteoarthritis of left knee. Second is patient also complains of abdominal pain. Here abdominal pain is an unrelated symptom. So along with a definitive diagnosis, you can code an unrelated sign or symptom. That is acceptable. So the appropriate codes here are M17.12 for unilateral primary osteoarthritis left knee, followed by R10.9 unspecified abdominal pain. And second case is the first point. This is one scenario. Codes for signs and symptoms may be reported in addition to related definitive diagnosis whenever the sign or symptom is not routinely associated. Sign or symptom, if it is not routinely associated, you can code. You need to code those signs and symptoms also along with the definitive diagnosis. Now coming to combination codes that include the symptoms. ICD-10 contains a number of combination codes that identify both the definitive diagnosis and common symptoms of that diagnosis. And when using one of these combination codes, additional code for the symptom is not required. Let us see an example. Patient presents with Crohn's disease of large intestine with intestinal obstruction. Here, intestinal obstruction is a symptom, but you have a combination code which governs K50.112. The definition for that code is Crohn's disease of large intestine with intestinal obstruction. Here, this combination code alone itself is sufficient. You need not code additionally intestinal obstruction also, because this is included in the code itself. K50.112, it describes Crohn's disease of large intestine with intestinal obstruction. So whenever combination codes that include the symptoms are present, that one code is sufficient. Additionally, you need not code symptoms as SDX. That is the guideline. Now next, repeated falls. The code R29.6 or repeated falls is used for encounters when the patient has been recently fallen and the reason for fall is being investigated. Additionally, code 91.Z91.81 history of falling is for the use when the patient has fallen in the past and is at risk for future falls. When appropriate, both codes R29.6 and Z91.81 may be assigned together. Let us see the examples. First case, patient visited the office to identify the reason for fall. Here, reason for fall is being investigated, and the physician ordered CT brain to find out the cause for fall. How do you code such scenario? The appropriate code is R29.6, repeated falls. Second case, patient has a history of falls and the patient visited today in the office due to sudden falls, and after examination, physician has diagnosed no injury and also ordered an MRI to know the cause of the fall. How do you code this? Here also the PDX would be R26.6 followed by Z91.81 to indicate the history of fall code also. Now coming to the guidelines regarding the Coma scale. Code R40.20. Unspecified coma may be assigned in conjunction with codes for any medical condition. And do not report codes for unspecified coma, individual or total Glasgow coma scales for the patient with the medically induced coma or sedated patients. These codes should not be reported for patients who have been medically induced coma or a sedated patient. That is important. Now coming to coma scale codes which come under the category R40.212, R40.24. These are further expandable, can be used in conjunction with traumatic brain injury codes. And these codes are primary for the use by trauma registries, but they may be used in the setting where this information is collected. And the coma scale code should be sequenced after the diagnosis codes. They can never be coded as PDX. They should be coded as SDX after the diagnosis code. And these codes, one from each subcategory, are needed to complete the scale. There are certain subcategories and one code from each subcategory is needed to complete the scale. And the seventh character indicates when the scale is recorded. And that seventh character should match all three codes. And at a minimum, report the initial score documented on presentation at your facility. This may be the score from emergency medicine technician, EMT, or in emergency department. Report the initial score documented on presentation at your setting or facility. If desired, a facility may choose to capture multiple coma scale scores. If desired, and assign code R40.24 Glasgow coma scale total score when only the total score is documented in the medical record and not the individual score. You can use the Glasgow coma scale only when total score is documented in the medical record, not the individual scores. And one more important guideline is if multiple coma scores are captured, within the first 24 hours after hospital admission, assign only the code for the score at the time of admission. And the ICD-10-CM does not classify coma scores that are reported after admission but less than 24 hours later. So if multiple coma scales are captured within the first 24 hours, then you need to assign only one code, only the code for the score at the time of admission within 24 hours time scale. Now let us see an example. This is a 26-year-old male who was assaulted by someone pushing him in front of a motor vehicle. The patient sustained an intracerebral hemorrhage of the right cerebrum due to the assault. The emergency medicine technicians, EMTs, state he lost consciousness for 25 minutes, and the Glasgow coma scales (GCS) scores were taken and documented by the EMTs. With response scores of eyes open 3, verbal response 2, and motor response 3. The EMTs provided immediate attention. And once the patient arrived at the hospital, he was treated and continued to recover. The GCS on day 3 was 14. Here the documentation of total Glasgow coma scale is there. That is 14. With patient opening eyes spontaneously and obeying commands on motor response. The patient was stable and discharged home to continue recovery. So here the first PDX would be S06.341A. Traumatic hemorrhage of right cerebrum with loss of consciousness of 30 minutes or less. Here they stated that patient lost consciousness for 25 minutes. So here 30 minutes or less initial encounter. A indicates initial encounter. The next is coma scale codes. R40.2131. Coma scale, eyes open to sound in the field, EMT or ambulance. The next is R40.2221. Coma scale, best verbal response, incomprehensive words in the field, EMT or ambulance. The next is R40.2331. Coma scale, best motor response, abnormal friction. And finally, R40.2414 for Glasgow coma scale score 13 to 14, 24 hours or more after hospital admission. And finally, Y code Y02.0XX assault by pushing or placing victim in front of motor vehicle initial encounter. Now coming to next guideline, SIRS, systemic inflammatory response syndrome due to non-infectious process. The systemic inflammatory response syndrome can develop as a result of certain non-infectious diseases such as trauma, malignant neoplasm, or pancreatitis. When SIRS is documented with a non-infectious condition and no subsequent infection is documented, the code for underlying condition such as injury should be assigned as PDX, followed by code either R65.10. SIRS of non-infectious origin without acute organ failure, or R65.11, systemic inflammatory response syndrome of non-infectious origin with acute organ failure. And additionally, when you report R65.11, you need to code additional acute organ failure codes also. And if any associated acute organ dysfunction is documented, the appropriate codes for specific type of organ dysfunction should also be documented in addition to R65.11. And if acute organ dysfunction is documented but it is not determined if the acute organ dysfunction is associated with SIRS or due to another condition, that is directly due to trauma, then you need to query the provider. Some more information regarding SIRS. SIRS is an inflammatory state affecting the whole body. It is exaggregated defense response of the body to a noxious stressor such as infection or trauma that trigger an acute inflammatory reaction, which may progress and result in the formation of blood clots, impaired fibrinolysis, and organ failure. Patients with SIRS will have two or more of the following symptoms: tachycardia, tachypnea, leukocytosis or leukopenia, fever, or rarely hypothermia. And the criteria for SIRS is temperature greater than 38 degrees Celsius or less than 36 degrees Celsius. The next is heart rate. It must be greater than 90 beats per minute. Respiration rate should be greater than 20 beats per minute. And white blood cell count should be greater than 12,000 cells per mm cube or less than 4,000 cells per mm cube. Either case. Now let us see an example. 27-year-old patient is admitted with fever, tachypnea and high lipase levels. The patient is diagnosed with SIRS due to acute pancreatitis. Code this as, what are the appropriate codes? First PDX would be K85.90, acute pancreatitis without necrosis or infection unspecified, followed by R65.10, systemic inflammatory response syndrome of non-infectious origin without acute organ dysfunction. Now coming to next guideline, death NOS, code R99, ill-defined and unknown cause of mortality only for use in the very limited circumstances. When the patient who has been already died has been brought dead or has been pronounced dead upon arrival. This is very rarely used and it does not represent the discharge disposition of death. It must be coded in very limited circumstances. Whenever the person who has already been died has been brought to ER department or other healthcare facility, or if the person is pronounced dead upon arrival, in that case also you can code that. And it does not represent the discharge disposition of death. Now coming to the final guideline, NIHSS, that is NIH stroke scale, which come under the category R29.7. They are further expandable, can be used in conjunction with acute stroke codes, which come under the category I63, to identify the patient's neurological status and severity of the stroke. And the stroke scale code should be sequenced after the acute stroke code diagnosis. At a minimum, report the initial score documented. If desired, a facility may choose to capture multiple stroke scale scores. Now coming to documentation by clinicians other than the patient provider. This is important for reporting the Coma scales and NIHSS scales. Usually the code assignment is based on the documentation by patient's provider. It can be the physician or other qualified healthcare practitioner, legally accountable for establishing the patient diagnosis. There are few exceptions where code assignment may be based on medical record documentation from clinicians who are not patients providers. These exceptions include the codes for body mass index, depth of non-pressure chronic ulcers, pressure ulcer stage, coma scale, NIH stroke scale, social determinants of health, laterality, blood alcohol level, under immunization status. And the BMI coma scale, NIHSS blood alcohol level codes, or the codes for social determinants of health and under immunization status should only be reported as secondary diagnosis. They cannot be reported as priors. A 62-year-old right-handed man with a history of essential hypertension presents with a sudden onset of aphasia and severe right hemiplegia within 2 hours of onset, concerning for ischemic stroke. He underwent a stroke code in the emergency department. His National Institute of Health stroke scale, NIHSS, score was 13 and his blood pressure was 162 by 95 mmHg. And his head CT was negative for bleeding and was both independently reviewed and discussed with the on-call radiologist. And a head CT angiogram was also performed, and there was an occlusion of left middle cerebral artery. An occlusion of left middle cerebral artery was found and the patient was admitted to the medical intensive care unit. Here the NIHSS scale score was 13. So first PDX would be occlusion of left middle cerebral artery, I63.512, cerebral infraction due to unspecified occlusion or stenosis of left middle cerebral artery, followed by I10, essential hypertension. And next, the NIHSS score, R29.713, which indicates NIHSS score of 13. Here you can see the score was 13. And these codes should be only given as SDX, not as PDX. By this, we complete the guidelines for chapter 18. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.